الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Non-Communicable Diseases, Epidemiology and Prevention by Professor Mahmoud Hani Sulaiman. In this lecture, I will talk about diabetes mellitus, epidemiology and prevention. Diabetes is defined as a state of chronic hyperglycemia due to an absolute or relative deficiency of insulin. Definition of diabetes. After at least 8 hours of fasting, venous glucose is measured. Patient is fed 75 grams of glucose, which equal about 300 kilocalorie. For children or anybody less than 50 kilogram, dose is adjusted as 1.75 gram per kilogram. After 2 hours of meal, a postprandial venous glucose is measured. Diabetes mellitus is fasting glucose more than 126 or postprandial more than 200 milligram or random venous glucose level is more than 200. Impaired fasting glucose is that glucose level of venous blood 110 to 125. Impaired glucose tolerance is postprandial 140 to less than 200. Problem of diabetes that will give us the magnitude of the problem. More than 220 million people worldwide have diabetes at the time of this slide, 2019. As you see, with increasing age, the prevalence of diabetes increase, and almost always males have more diabetes than females. Again, this shows the problem in Egypt. Prevalence of type 2 diabetes in Egypt. The first one above shows the prevalence. Prevalence of type 2 diabetes now is about 16% and will be about 18% in 2030. The lower picture shows number now about 10 million, and it will be about 14 millions at 2035. Again, these are the top countries in the Mediterranean area of people with diabetes in 2019 till 2030 and 2045. Now at 2019, Egypt is the ninth country. The number of people with diabetes are about 9 millions. In 2030, it will be the 8th country, and this is of all the world. It will be about 12. In 2045, it will be the 7th and the number will be about 17. What are the types of diabetes? Type 1, autoimmune, of early onset, fatal without treatment, and ketosis is common. Type 2 diabetes, which is more prevalent, insulin resistant, slow process associated with metabolic syndrome, complicated by other diseases. Gestational diabetes in pregnancy, due to growth hormone, progesterone, cortisol, and prolactin excess. Maturity onset diabetes in young, genetic beta cell malfunction. Lipotrophic diabetes, genetic defect in insulin action. Disease of exocrine pancreas, endocrine diseases, pheochromocytoma, Cushing syndrome, and acromegaly. Hyperthyroidism, drug-induced due to steroids, thiazides, phenytoin, niacin. Congenital disease as Down syndrome, Klinefelter syndrome, Turner syndrome, Friedreich's ataxia. Atherogenic dyslipidemia, which means elevated triglyceride levels, smaller LDL particle size, and low HDL cholesterol, raised blood pressure, insulin resistance with or without glucose intolerance, prothrombotic, pro-inflammatory states. This is the MS metabolic syndrome. Metabolic syndrome continued is associated with prediction of both diabetes and cardiovascular disease independent of other factors. It is hypothesized that clinical improvement in these factors may prevent or delay the onset of diabetes and the onset of cardiovascular disease. Type 1 diabetes mellitus. Type 1 diabetes has a rapid, discernible onset, usually before 30 years of age. It is usually autoimmune in origin, insulin dependent, and develops ketoacidosis if untreated. The agent in type 1 diabetes infections may be mumps, Coxsackie virus, cytomegalic virus, and rubella. Nutrition, early introduction of cow's milk, autoimmunity against islet cells, glutamic acid decarboxylase, genetic associated with HLA-DR3 and DR4. HLA-DR3 and DR4. Type 2 diabetes mellitus. The agent, insulin resistance, seems to be primary pathology. Up to a certain age, this resistance is countered by increase in secretion until beta cell dysfunction sets in and insulin production drops. Insulin resistance is brought on in first place by rapid rise of blood glucose after regular meals of refined sugars, as burgers, colas, and candies, along with obesity. The host in type 2 diabetes is the age. Type 2 diabetes usually comes to light only after 30, and many people in the world live with it without being aware of it. 6. In some countries, type 2 diabetes increase in male. Genetic. Family history of type 2 diabetes is a risk factor. Central obesity with circumference more than 107 centimeters in males, 107 centimeters in males, 88 centimeters in females, carries a high risk of type 2 diabetes. Habitual physical inactivity. Maternal diabetes may occur during pregnancy, so the host factors are age, sex, genetic, central obesity, physical inactivity, and maternal diabetes. Environment, diet, increased saturated fatty acid, refined carbohydrates, decrease dietary fibers, and decrease polyunsaturated fatty acids. So increase in saturated fatty acids, refined carbohydrates increased, decrease dietary fibers, decreased polyunsaturated fatty acids. Egyptian children and teenagers began to acquire all bad food habits of West since the last 2 decades. Type 2 diabetes is on the rise in children. Stress, physical, like trauma and surgery, or mental stress may bring out latent diabetes. What are the differences between type 1 and type 2 diabetes mellitus? Type 1, onset less than 30 years. Ketosis is common. Body weight, it will have weight loss. Genetic, 90% of cases are genetic. Circulating cell antibody present. Associated autoimmune disease present. Treatment with insulin. Insulin level is decreased. Insulin resistance uncommon. What about type 2 diabetes? Type 2 diabetes, the onset mostly after 40 years of age. Ketosis is uncommon. Body weight occurs more in obese. Genetic, 50% of cases. Circulating cell antibody absent. Associated autoimmune disease absent. Treatment, oral and insulin. Insulin level increased or decreased. Insulin resistance is usual. Criteria for classification of diabetes. The disease is either gestational or prediabetes or frank diabetes. There is difference between the WHO, some little differences, WHO classification and ADA classification. I will leave it to you to read it and try to find the differences between both definitions. Complication of diabetes. Diabetes increase risk of heart disease and stroke. So heart disease and stroke are increased among diabetics. 50% of people with diabetes die of CVDs, heart disease and stroke. Decreased blood flow. There is prevalence increase in decreased blood flow. Neuropathy in feet. Increased chance of foot ulcers and limb amputation. These are the complications of diabetes. Diabetic retinopathy is another complication. It is important because it causes blindness and occurs due to long-term damage to small blood vessels in retina. After 15 years of diabetes, 2% become blind and 10% develop severe visual impairment. Another complication is kidney failure. 10 to 20% of diabetics die of kidney failure. Neuropathy is another complication due to diabetes and affects more than 50% of diabetics. Common symptoms are tingling, pain, numbness, or weakness in feet and hands. The overall risk of dying of diabetics is at least double the risk of their peers without diabetes. So diabetes double the overall risk of dying. Primary prevention of diabetes. Population strategy for primary prevention. Type 1 diabetes is not practically preventable except for genetic counseling. We can only prevent type 2 diabetes through change in lifestyle, habits, and activity. Type 2 diabetes, change in lifestyle, habits, and activity. Dietary goals by WHO must be followed, but diabetes cannot only be controlled by dieting. Patient must rethink his priorities of life. allow himself to slow down if just a little. High risk strategy for primary prevention: concentrate to eliminate risk factors among first degree relatives of diabetes patient, obese, those with impaired glucose tolerance. So the high risk people, first degree relatives of diabetics, obese, and those with impaired glucose tolerance. Secondary prevention of diabetes. Screening. Target population for screening for diabetes are those who are more than 40 years, those with positive family history, obese ones, women with babies more than 4.5 kilogram at birth, excess weight gain in pregnancy, premature atherosclerosis. So target population for screening in order to make secondary prevention are those people more than 48 years of age, positive family history, obese, women with babies more than 4.5 kilogram at birth, excess weight gain in pregnancy, premature atherosclerosis. There are two methods for screening. Glucosuria, this test is neither very sensitive nor specific, or oral glucose tolerance test, which is better, and measure it in venous blood. Oral glucose tolerance test, this is the detail. Patients should take good carbohydrate meal 3 days prior to test and should avoid all kinds of drugs or exercise that will affect blood glucose level. Further, he should consume 30 to 50 grams of carbohydrate the prior evening. Next, he should do at least 8 hours fasting before the test. So these are the preparation for doing the test. Then blood is collected at fasting state from a vein and glucose is estimated. Normally it should be 75 to 110 milligram per deciliter. This is the normal range. Then the subject is fed 75 gram glucose in 250 to 300 milli of water. 75 gram of glucose. Then blood and urine collected at half-hour intervals for 2.5 hours. Then in normal person, blood glucose should be 110 to 140 milligram per deciliter maximum. This is the curve drawn after glucose tolerance test. The normal curve is the lower one. This is the normal curve. The alimentary glucosuria is the one above it, this one. The impaired glucose tolerance is this curve. The diabetes mellitus is this one, the upper one. So 4 types: normal, alimentary glucosuria, impaired glucose tolerance, and diabetes mellitus. Print it and look at it carefully and try to see if what we mentioned in the previous slide is true or not. Treatment of diabetes mellitus: consult a textbook of internal medicine. Monitoring of therapy. This is important. Monitoring of therapy to ensure that the case is compensated. It is under control. Blood sugar, urine, blood pressure, visual acuity, and fundoscope, weight, examination of vascular supply of feet, glycosylated hemoglobin. Most of monitoring can be done by patients through appropriate self-care devices. Most of monitoring can be done by patients through appropriate self-care devices, and this is through health education. Tertiary prevention of diabetes. Save the diabetic foot and eyes. Prevent other disabilities as ischemic heart disease and renal failure. The patient can still lead a good life. وفي النهاية أقول الحمد لله رب العالمين و thank you for your good listening.